Welcome, everyone, to the Four Eyes podcast brought to you by YoungOD Connect. We give you a clear view into the young optometry world across Canada and the US. And we are your hosts. I'm Dr. Amrit Bilku.
And I'm Dr. Deepan Kaur.
And we are joined again by Dr. Sophia Leung. She is a cornea optometrist working in Calgary, Alberta. And we were lucky enough to have her in part one of our episode that you guys hopefully have heard before, where we got lots of details about a day in the life of a cornea specialist, your journey into cornea, how you fell in love with it, your journey in residency, and all that stuff. But we're really excited to continue this episode talking about how to approach the cornea, how to manage it, how to refer, when to refer, all of those types of things. As an OD who offers, primary care and doesn't focus on the cornea every single day, how would you recommend we approach handling corneal diseases or conditions? Where would we start?
Yeah. Well, it's funny because the cornea, you're actually probably looking at it more than you realize. I mean, you're looking at it every day. You have to look through it to get to anything. And so even those healthy ones, you're kind of like, there's going to be nothing there. I'm just going to blow right past it. I would maybe encourage anyone to just take a step back and spend an extra 2 seconds, right? And especially when you're just trying to learn the cornea and get to know it well. You'd be surprised at how much, let's say, EBMD gets missed just because we're scanning right through it really quickly. And so as a practice, just like anything else, get to know what a really healthy cornea looks like and get to know when something is looking atypical. And so that's kind of the very first start. If you are paying attention to the cornea, not just scanning really quickly and saying, okay, it's clear, look for the epithelium, look at the stroma, look at the endothelium, and just see through those layers and see, is there anything going on? Because I would bet that you're going to start picking up more mapped out fingerprint lines. You're going to start to catch a little more SBK than you realize. You're going to start to pick up pigment on endo. You're going to start to pick gutata. All these little subtle things that are in very, very small cases, pretty inconsequential. They will show up later on. And so just by trying to identify some of those things in a regular exam that you don't expect there to be anything at all, I think you'll be surprised that you're going to start to see things. And so even starting with that, to force yourself to slow it down a little bit, make sure you're seeing all the quadrants of the cornea, because we oftentimes will scan through the center, looks good, quick up and down, look at the conch and the lashes, but you're actually going to be missing the top third and the lower third of the cornea. And if you're going really quickly, you're going to miss that subtle neovasc, you're going to miss subtle epithelial microcyst, all that. And so you'd be surprised at how much actually is already there. Just taking a bit more time is a really, really good start.
Yeah, that is actually a good reminder for me because I do exactly what you said. Just don't do.
Yeah.
Scan, it's clear, good. All right, let's push through, get to the lens.
Yeah.
No, you're right, because there are so many little imperfections in the cornea too. And if you're skimming through it all the time, you don't really know if that imperfection is non-urgent, if it's nothing we really need to bother with, or if it's the start of a corneal dystrophy. How would you recommend that we, approach those situations where we see something abnormal on the cornea, but we don't really know what it is and if we need to address it or not?
Yeah. Very good question. Oftentimes I look at a cornea and I'm like, I don't know what's going on. So, it's for all those who are like, I just, it happens all the time. And to be honest, it happens to cornea specialists and corneal ophthalmologists too, because we've had cases where I'll bring him in and be like, take a look at this. And you're like, I'm like, cool. How do you chart that, right? But I think a lot of times it's going into understanding how the tissue interaction will be and what you expect of a regular normal healing cornea. So one thing to start approaching that, for example, you see abrasions all the time, right? In primary care, you're going to see the foreign cornea bodies, and those are really good ones to actually, you can bring the patient back just for your own learning a little bit, and obviously don't do it excessively because the patients, they have lives too. But let's say you remove a typical metal piece and there's a little rust ring there, and typically that you probably can send this patient off maybe for a month. bring them back in a week and just kind of see your own work, right? And even though you're
Mhm.
going to expect that everything's going to be clear, the patient will be fine, but pay attention very closely to the movement of that rest ring. See how it moves forward. See if it does
Mhm.
clear out. See around the actual rest ring and notice the slight kind of haze that's forming around it, just so you can know the process of how the epithelium and the anterior stroma is healing. Because
Mhm.
even just in that, if you can see that, let's say, for example, someone comes in and let's talk about neurotrophic keratitis, for example. So they come in, they've got an ulcer, they've got some kind of abrasion, you're not really sure what it is. They're not in a lot of pain, right? You can see by the way the tissue looks, you can see by the edges whether or not that's actually something that's non-healing for a while and the epithelium is trying to heal in because it rolls, right? And so
Mhm.
by that we know, what do we know? The epithelium, it's the cells will migrate in towards and fill any surface area. And there's still going to be looseness there, right? Which is why you can get the swelling after, let's say, like a abrasion, that healing normally, about day 7 or day 10, you can still see where it was. And there's kind of this loose tissue that's kind of there. And that's usually what a normal healing cornea that hasn't had the tissue tacking down will do. But in that period, you are looking at essentially a potential EBMD case, right? As well. So
Mhm.
you're already in that sort of normal healing progression. If it's not healing, that epithelium is getting stuck and is going to try to heal, but it can't. So it's not really going anywhere. And because
Mhm.
those nerves there are not telling the brain we need more healing. And so the
Mhm.
epithelial migration stops. You're getting this rolled tissue. So that rolled edge already tells you it's probably been there for a while, right?
Oh.
And if
Mhm.
it is healing in, then you can see, is that tissue smoothing it out over time or is it still loose? Because if it's still loose after a week or after 2 weeks, then now you're at a risk of RCE, right? And
Yeah.
so just by kind of knowing what that should look like and watching what the tissue interaction looks like, you're already trying to figure out what's going on there. And then the patient symptoms will tell you a lot. But that's sort of the kind of underlying sort of clinical judgment that you're making every single time you see something different. And so when you look at something and before you panic and you're like, I don't know what this is, and then your mind shuts down, which still happens to me. I'm kind of like,
Mhm.
ugh.
Yeah.
You can tell yourself, hang on a second, like I know what's supposed to happen here, right? And so if we're just sticking to the cornea, the epithelium, for example, then yeah, every time you remove a foreign body and okay, I know roughly the depth that I've taken a look at, and you can even image an OCT to kind of see,
Yeah.
make yourself a little bit of learning to see how deep you've gone.
Mhm.
But
Yeah.
you know how deep you've gone, you know the divoting that you created, and now you can kind of observe or try to predict what is going to happen. So if you bring this patient back in a week, if it's fairly small, then and you left a bit of rest in there, that rest ring should keep getting pushed up and it's not going to clear away completely, but either two things can happen. One is that they're going to have an inflammatory reaction around that rest ring, which makes sense because the body's saying, I don't like this being here.
Mhm.
Or it'll seal in, it'll be just fine. It may be very faint, but it's going to be anterior enough that it's not going to trigger much of a response, right?
Yeah.
And so
Mm.
those are kind of some things that you can already kind of tell just by something that is happening in primary care every single day.
Hmm.
Um, but understanding, for example, another kind of to go on a little bit more, the stroma is highly, highly inflammatory. It has a
Yeah.
significant immune response to a lot of things. And so when you start to see, let's say, a rust ring that you would expect to see just plainly as a rust ring, or you see and they're coming back and you see sort of that haziness that's kind of coming out there, now you're starting to learn what early or sort of mild inflammatory reaction at the stromal level looks like. And when you
Mhm.
start to recognize that more and more and more, then now you can translate it over to, okay, now you've got a herpetic scar, for example. You
Yeah.
can actually tell when a herpetic scar is flaring up by looking at the edges and seeing how that stroma is getting more hazy, maybe a little bit more edematous, and it's going to cut this sort of haze that's actually causing a little bit of almost like a cystic edema appearance to it.
Mm.
You can actually see epithelial edema forming around it because focally you're getting a lot of focal swelling there. So
Yeah.
now you've taken what you just were observing from a rest ring or a foreign body removal, and you're moving into what is the stroma doing there. And now you're
Mhm.
looking at, is this an inflammatory reaction or not, right? So even in just that, you're going to start to learn what the tissue interaction is looking like and how it's supposed to behave. And all of it really is just a matter of getting to know how a tissue is supposed to behave. And once you are more familiar with that, then you'll see when something is going off. And again, you may not know exactly where it's headed, but you'll know when something is off. And so
Hmm.
that taking that time to just, in very typical cases, things that are fairly inconsequential, you remove the foreign body, put them on an antibiotic or something,
Mhm.
and then you bring them back, and you know how it's going to happen, right?
Yeah.
But now you're looking at it a little bit more deeply and almost looking at how the tissue is responding. That's going to be your best way to familiarize with how epithelial healing is supposed to be, how the anterior stroma heals, and picking up early inflammation as well.
And
Wow.
if we see that stromal haze or that inflammatory reaction, that's okay to put the steroid over
Yeah.
that. Right.
Yeah,
Okay.
absolutely. Yeah.
Okay.
Um, so steroids, of course, you can put it on when there is that inflammatory reaction, but you have to always be careful with basically the epithelium, right? And so
Right.
that's the tricky part is not, let's say you're looking at, let's say a foreign body that you removed. Let's say you did a follow-up in 3 days. Let's maybe not make so long. Let's say you did 3 days and it's not really quite healed up. The question is, do you put a steroid and it's got haze? Let's add
Mhm.
let's make it more
Yeah.
complicated and
No.
say, do you add, yeah, just kidding.
Demon's
So
like,
and
I
that's how
don't
it shows
want
up, right? Yeah, that's how
it.
yeah,
Prefer.
no, you don't have to refer that. So, the big thing is that you know that there is inflammation there. You know you have to do something, right?
Yeah.
And so that's gonna then you're gonna see that a lot. A lot of times it's not gonna be cut and dry where
Yeah.
epithelium is good, now the stroma is gonna come in. You're gonna have to balance very carefully what you expect to
Mm.
happen. So that's where measurements are really key. I find that a lot of people who are dealing with abrasions and things like that, just having it as abrasion, superior quadrant, or whatever is not enough. Measure them as best as you can because for one
Okay.
thing,
Yeah.
you want to know if it's getting better. If you are
Better.
co-imaging, they also will probably want to know whether it's
Mhm.
getting better. But if
Hmm.
that tissue is starting to close in, you see that inflammation coming in, you can put a steroid on that. As long as you've got an
Mhm.
antibiotic coverage, you can put a steroid on that. But if it has
Okay. Yeah.
at all, it's not moved, you're like, okay, there's non-healing there, then you have to be careful, right?
Mhm.
Because if you're going to put a steroid on it, it's going to slow down the healing even more. So
Yes.
Hmm.
it really comes down to that progression, as far as sort of whether you're going to put it on or not. And after a while of being more familiar with it, you'll kind of know when to put the steroid on. But when you're just starting off, you're not sure. You're not in the wrong to bring a patient back for follow-up, right?
Yeah.
Yeah.
Yeah, it's going to be inconvenient for the patient, but you're also saving their eyes. So,
Yeah.
Yeah.
really just kind of like, do you want to miss a day of work and then potentially risk having something really bad happen? It's okay to explain to a patient, this is what I'm watching for, and this is what I'm bringing you back for, right?
Hmm.
I do have a random question about a foreign body. Is the
Yeah.
standard of care doing a follow-up the next day, or are you kind of like like how you said these
Um,
people have lives too, like but
yeah.
Hmm. Yeah.
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 When
Okay.
I was first doing it, I was bringing them back very often.
Mhm.
But nowadays, if you're removing it, and to be honest, I actually don't do a ton of them because they're all done in primary care.
Yeah.
I only get the ones that are kind of more complex, but I don't think these have to be kind of same day follow-ups. If it's really deep and you've dug it out and you're kind of like, ooh, that was almost like into like post-stroma.
Mhm.
Yeah, you may want to take a look and make sure, but it was same next day is probably too early.
Too early. Yeah.
You want to
Okay.
maybe give it like a week or something
Okay.
like that. Yeah.
Yeah.
Okay.
Kind of adding on to epithelial defects and things like that.
Yeah.
Bandage contact lenses are always something that I'm not 100% sure on.
Yeah.
Obviously, when there's like a very, very large defect and the patient's in
Yeah.
a lot of pain, a
Yeah.
bandage lens will go on. But sometimes there's those situations where I don't know if a bandage lens is going to delay the epithelium from also healing because
Right.
then, you're also putting something else on the
Yeah.
eye. You don't
Right.
know if that bandage lens is also going to trigger some bacterial growth. And
Mhm.
then how often do you follow up with those patients? And what type of contact lens do you offer as a bandage lens?
Yeah. So I probably say a daily might be from an oxygen permissibility standpoint might be a little bit too low. Although
Yeah.
arguably actually a lot of them are actually fine for like a day or two, to be honest. If that's all you
Yeah.
have, then use it. But I'd probably go with like a biweekly or monthly, something like that
Hmm.
that can last a bit longer. Depending on how massive this abrasion is or something like that. We not to say this is kind of your go-to, but we have patients who have a bandage contact lens 3 months at a time. And that's,
Oh,
they're
wow.
very we know what's going on. They're stable. They're
Mhm.
on the prophylactic antibiotic. But let's say you've got an abrasion, or honestly, even a non-healing neurotrophic ulcer. Let's say, we know that they're having trouble healing. A bandage contact lens is really helpful
Yeah.
Mhm.
because it is providing basically that barrier to try to remove the mechanical forces that would be
Hmm.
shearing that epithelium off every time. So most of the time, it's actually going to be very helpful unless there's an active infection going on. Then you don't want
Yeah.
to put a bandage contact lens on there
Mhm.
because the risk is, of course, exactly like you said, you're creating the perfect environment for a biofilm to form, and you're
Yeah.
just cooking it basically.
Mhm.
So,
Yeah.
outside of, if you're fairly sure it's sterile, if you're fairly sure that there's not an infection, currently happening, a bandage contact lens is going to be a really good tool, as well as an amniotic membrane underneath it as well. So,
Hmm.
if you have a situation where it's non-healing, and kind of that question about do I put a steroid on, do I not, right? And a really helpful tool is to put an amniotic membrane underneath it, put it right on with the contact lens over top, and it's going to
Hmm.
give the cornea new scaffolding, new tissue, new epithelial tissue and stem cells to be able to heal that.
Yep.
But anytime you're putting a bandaged contact lens, you absolutely have to cover with an antibiotic of some kind,
Yeah.
because you
Mhm.
have to protect that. You know they're going to be sleeping in it, right? Um,
Yes.
so
Yeah.
yeah, I think there's lots of roles for bandaged contact lens to play. Don't shy away from them. They're very helpful,
Yeah.
especially if the patient is in pain. It's amazing how much just putting a contact lens on there, you can instantly see. And actually, a lot of times for patients, if they can tolerate it, like for a lot of my RCE patients, I'll try to put the contact lens on without staining if or without numbing if I can.
Hmm.
Obviously, if you have massive abrasion, then you have to because they're not going to open their eyes for you. But if
Yeah.
it's something that's got something chronic going on, and they can manage having you put the lens on without having a numbing agent in there, um, this is pretty rare. I mean, most of the time you do put the numbing agent on there.
Yeah.
And even with that, they'll start to feel better right away. So
Yeah.
it's a really, really good tool to have. And if you find yourself actually having to reach for contact lenses often, you could ask the contact lens company just to give you basically a set that is a trial set, but for bandaged contact lens only.
Yeah.
And that way you're
Mhm.
not having to purchase it more or anything like that. And most companies are willing to work with you for that.
I just
Mhm.
learned that last week.
Yeah,
Yeah.
there you go. Yeah, you
I saw
definitely.
these trials that Dr. Farbaha ordered and it just says bandage lenses and I was like, "Oh
Yeah,
damn, these come by
yeah,
themselves. All right. I can
yeah,
stop wasting my trial
yeah.
lenses." Or
Right. Yeah, for
Oh, I
sure.
didn't even know that. Okay, well, that's good to
yeah,
know. I'll
yeah,
ask
I
our
just
contact
that's
lens
so
company for
funny.
that. I
Yeah.
didn't know
Just
that.
learned that.
Um, no, you just talked about recurrent corneal erosions.
Yeah.
When is the point in time where it's kind of like, okay, now we really need to refer? Because is there any
Yeah.
like surgery, corneal surgery that can be done
Ah,
to
yep.
basically help with it? Yeah, when's the point where it's like, okay,
Mhm.
we probably need to get you to a corneal specialist or
Yeah.
someone like you to kind of
Yeah.
help with this situation?
So, I mean, a lot of your conservative therapies initially, you're going to throw kind of the dry eye books at it, right?
Mhm.
Is it if it's basically kind of let's say let's break it down into different kinds of RCs for a moment because there's lots of different kinds.
Mhm.
If it's your micro erosions, then you can see whether or not just having a really good overnight barrier, like an ointment of some kind,
Right.
Miro, Ocunox, whatever, take your pick. So having that and seeing if just try to fix that and giving it more time for it to actually heal if that might actually be enough to reduce those recurrences. Um, so that's usually kind of first go to, or you can try a contact lens for a while. A contact lens for a while, maybe an immunomodulator of some kind. Cyclosporin tends to work really well for that kind of
Mhm.
thing, because a cyclosporin actually can help with reducing the, let's say the MMP9s and whatnot,
Right.
similar to a steroid without slowing down the healing. So that's a really
Yeah.
good tool to have and to throw on there. If it's like a macroerosion, they're in massive pain and things like that. You might want to even consider debriding some of that loose tissue and letting that
Mhm.
kind of come off because it needs new tissue to grow back, right? And so,
Mm.
Right.
by if you're looking at it as flapping in the wind, or if you do a tester and you're touching with a surgical spear or a cotton swab and it's sliding around everywhere, if it's already broken, you can very carefully take some forceps and just very, very gently debride it as you would if there was like an abrasion that's got some loose tissue. Just be cautious though, because if it's EBMD or, if it's EBMD or let's say it's from like a fingernail scratch, something like that,
Mhm.
chances are when you touch it and you start to debride, a lot of a bigger area is going to come off with it. So
Yeah.
you just have
Oh.
to be careful. And if you are debriding, you're kind of stuck in that situation. Don't panic, but just try not to peel away from the initial abrasion. Try to peel inwards towards the center. So you're actually grabbing tissue and not pulling it and ripping it apart, right? And
Yeah.
Oh,
so
okay.
Yeah.
you just want to be careful with that.
You
But
explaining this sounds so painful to me. I'm just
Yeah,
like,
I know. We
yeah,
forget that the patient's already numb, so they don't feel it. But
yeah.
I'm just like, oh my God, they'd be screaming in the
I'm
chair.
like, I
Oh, they and these ones are painful.
Yeah.
Unless they're neurotrophic, they will hit you a little bit. But yeah, they are numbed up when you're doing this, of course. But oftentimes, if you kind of were to test it, you'll notice the tissue is just so loose there, and you know exactly what areas are already limping up
Hmm.
every single time. A bandaged contact lens does work well for that, but it's not going to remove the issue of it not healing down, right?
Yeah.
And so in those cases, when you've already tried the contact lenses, you tried, maybe a few topical therapies, maybe even some oral, like oral doxy or something like that. If you're
Mhm.
running into recurrences still and they're not able to be out of their contact lenses, those are usually good times to
Hmm.
refer. And what's really helpful is listing off what you tried and kind of, how many recurrences they have,
Right.
if they're getting them weekly, monthly, that kind of thing. that's all helpful because what oftentimes is at a corneal practice, we have to test it out, right? We have to see, okay, what is your
Oh,
frequency of it? And sometimes we have to make them go with other contact lenses to force them into an erosion just so we can see how
How
drastic
bad
and
it is.
severe it is, which sounds cruel, but we have to know whether it justifies the surgery or not.
Right. Yeah.
From a surgical approach to that point, if it's focal enough, you can do an anterior stromal puncture, which is basically using, usually if you can actually do an ASP needle, or you can use like a bent needle tip to create microcystic microfibrotic reaction to let the tissue kind of grapple underneath. You're actually purposely breaking the Bowman's to allow it to hook so that it basically you're forcing it
mm,
to make its own adhesions.
Mhm.
That can work really well when it's focal and outside of the visual axis because you will get scarring
mm,
from it.
Okay.
And that can be done on a very small scale. But if it's a larger area, then now we're talking about a full corneal debridement or a superficial keratectomy. And in the States, actually, in a lot of jurisdictions, that actually can be done by optometrists. I used to do them
oh
in Oklahoma.
wow, that is
And
Oh.
awesome.
so, yeah. And so in Canada, it's not quite like that, but
Mhm.
a cornea specialist can go and do that depending on if they've had a lot of recurrences or obviously if they can't keep getting a contact lens put in there and things like that. You can also do it with the laser, so PTK, phototherapeutic keratectomy. You can also do it that way as well. The only difficulty with that is that it would change the prescription, so that's not always as ideal because you're using the laser now
Mm.
to try to get underneath the layer that's not healing, letting it grow back. So it's not done as often anymore. It still can be, but a good debridement with the diamond burr polish will also do that as well too.
Hmm.
Um, but yeah, those are kind of the more advanced cases, of course. But
Yeah.
I will point out that the surgery is not meant to completely stop any recurrences. It's just
Yeah.
to
Mhm.
reduce them. By
Yeah.
that, if it goes down to once or twice a year, that's still considered a success, right? And so
Okay.
patients need to know that they're going to undergo
Yeah.
a surgery not to completely rid it of any potential recurrences down the road. They still probably have the underlying dry disease. They probably still have
Mhm.
underlying ocular surface disease. It's just about trying to get new tissue to grow so it has a better chance of tackling down there. So, yeah, that's kind of the range of treatments, I guess you could say.
Mhm.
But a lot of it can be done at a primary care level. It just has to, you just have to be really careful that when you're about to debride a little bit of that tissue, that you're aware that if this is EBMD or if it's been there for a long time, if they're getting macro erosions, chances are more tissue will lift off than the area that you think you're treating.
Mhm.
Gotta be really careful.
What tools do you use to debride the cornea?
Yeah. I really like the Waxel surgical spears. They're
Okay.
disposable, they're clean, and they have a little when they're dry, they have enough stiffness, I guess, that they can remove
Mm.
tissue. A good golf spud is also great
Okay.
because you can actually literally just kind of wipe away. Forceps are good, but you just have to be really careful because what you don't want to do
Mhm.
is be debriding with your forceps. But once it's lifted, you can grab those rolled edges and kind of start peeling away. But be really careful because you just don't want to be scraping more than you want to, I guess. Some people use like a spatula, and I think it's almost a little bit too wide. Those are really good for
Mhm.
corner scrapings, but it's a bit too wide. But I do like a combination of the surgical spear, a golf spud, and then forceps, kind of the more rounded ones, so that you can actually grab the tissue and kind of work your way around there that way. And
Mm.
lots of buffer saline
Oh,
solution to rinse off as needed,
Wow,
depending on
nice.
if you're working under a scope versus if you're doing it at the slit lamp. Yeah, if you're doing a full debridement, for those folks in the US that are doing this or want to
Mhm.
get into it, you want to make sure that you have a lid speculum as well to hold the eyelid
oh,
open. Yeah, because
oh,
otherwise, if they're blinking into what you're doing, you're like, ah, you're just losing all the tissue.
yeah.
So, yeah, yeah, that's a mess. Yeah,
Oh, I always
Um,
forget about lid speculums. I'm always like, yeah, just kind of tugging
yeah,
their eyelids, trying to get that
yeah.
foreign body out. And I'm like, don't move. Don't
Yeah.
move.
And they're honestly, lid speculums are great to have at the primary care
Yeah.
level too, because
mhm.
you numb them up. It's a little tight to fit at first, but once it's on there, you don't have to worry about them exactly blinking into what you're trying to do. You
Yeah.
don't have to worry about,
Yeah.
I don't know if you that satisfying, you get that one foreign body out. It's that perfect divot, and you're like, I've got it. And then they blink, you're like, it's
Yeah.
gone, you know?
And then
And so
yeah,
it
you
just helps
gotta
to control
move.
that blink reflex. And even putting a contact lens on, it's much easier with the lid speculum if you got
Yeah.
someone with really tight lids, and having that in there just makes their life so much easier.
Yeah.
Yeah. No, I'm
Sure.
like Amaret. I'm just trying to pry their eye open and I'm like,
Yeah.
Yeah. All the
okay,
time.
this is normal. This is
Yeah,
normal
yeah. You
frustration
love
from
it.
All
It
this.
feels great. Yeah. Yeah.
We just went over a lot of the epithelial and then kind of stromal things that we can see
Yeah.
and how to manage them. Of course, because with optometry, we can, deal with a lot of epithelial issues and stromal without needing an ophthalmologist involved. What about endothelial issues?
Mm, yeah,
What are the most common endothelial, findings that we
yeah,
can see in a primary care setting? What can we manage and
yeah,
what do we have to send out for further investigation? Because that's what
yeah.
I'm always a little iffy on.
Sure. So, Fuchs endothelial dystrophy will probably be one of the more common ones. And so, that's when you're trying to pick for the gutata and trying to see that
Hmm.
that's really good practice just to start looking for it because technically, Fuchs endothelial dystrophy, the stages of it, you don't really need to be referring at the very beginning stages. Now, that might change as different surgical options become more available, but right now, if you're talking about like a DSEC or a DMEC, corneal transplant to replace that endothelial layer, that will usually come later on. And so a patient will actually be able to tolerate quite a bit of stromal edema because the epithelium or the endothelium is breaking down. They can handle a lot of stromal edema before it becomes blurry for them. But as soon as the epithelium gets involved, like a bullous keratopathy, or if it becomes epithelial edema, then all of a sudden they're gonna have pain, they're gonna have blurred vision. But once you start seeing some of the gutata, you want to start thinking about when you want to introduce some of your hyperosmotic agents, right? So,
Hmm.
there's Miro, there's Lab Relief, there's a bunch of different ones in the US as well too. But those options are really helpful to start talking to the patient about, just so that they're aware this is why your vision is blurry in the morning and those kinds of things. So, you can actually manage quite a bit until that point where it becomes they're noticing a lot and you're seeing that visual acuity drop, or you're starting to see those endothelial buckling. And so there's actually kind of at sort of the mild to moderate, well, I would say probably moderate to advanced stages, you can start to see that the actually Descemet's membrane endothelium starts to show stria essentially. And it
Hmm.
almost just looks exactly like that, these kind of line and folds that are starting to happen. You can also start to see this sort of subepithelial haze that starts to form, and that's from chronic inflammation going in and out, in and out. And so that's when those patients will start to have a little bit more symptoms, especially when they're trying to, yeah, if they're driving, that kind of thing, they're going to notice the glare. If you're trying to refract them, it's just not going to get clear, those kind of
Yeah.
things. And usually those are the points where it might be good to start sending them in for an assessment. Um, if you have a patient who might have maybe mild Fuchs dystrophy and cataracts, a lot of times a cataract surgeon who is also a cornea specialist will consider doing combo surgery. And so mainly because if you're doing cataract surgery, you get any kind of lens coming up, or if they don't have extra visco in there or something, it will likely disrupt the endothelium a little bit. And
Yeah.
these patients are going to be more prone to haziness or swelling and whatnot. So yeah, Fuchs dystrophy is probably going to be one that's very commonly encountered, I think, in the primary care space.
Hmm.
Um, I think more than probably we realize, I think that a herpetic endotheliitis is common. That's actually and common is maybe not the evidence-based word. I mean, it's going to be more common than we realize, and how we know that that's happening is going to look like almost just a collective of almost like KPs. It's going to seem like there's a bunch of stuff in this focal area, and you're going to see this overlying stromal haze over top of it. And usually, if you see that, then unless there's been some kind of pre-existing damage there, or like a forceps injury when they were a baby or something like that, those are ones to consider steroids, and then also maybe some antiviral prophylactically as well too, just to try to
Hmm.
get that down. Because they actually found that herpetic endotheliitis is actually maybe some herpetic antigens accumulating on the endothelium and causing an inflammatory reaction. And now the body comes in and tries to trigger a response to clear that. And so that's one that might sneak in there and take you by surprise as well too.
Wow.
Gosh, I just forgot about KPs and then you reminded me. And I'm like,
Yeah.
ah!
Yeah, there they are. Yeah, yeah. But to that point, right, a uveitis with KPs, that's an endothelial issue too in some cases. And
Yeah.
someone's already got Fuchs dystrophy and then they get a bad uveitis flare and they get KPs on that. Well, what's happening there? You're getting protein clumping on the endothelium is already sort of, at risk, and now you're going to get a trigger of your Fuchs dystrophy, right? So all of that can be managed within the optometry space.
Hmm.
But if you're finding that, you're putting the steroids on, for example, you're putting the hyperosmotics and it's really declining, or, the vision acuity is really bothersome, then yeah, that can be worth a referral in for another assessment or maybe a surgical intervention as well, too, especially if that
Yeah.
endothelium needs to be replaced.
I have a question about a case that I sent to the ophthalmologist that you work with. I think it
Yeah.
was Dr. Al Ghul.
Yeah.
I thought initially it was dry eye.
Yeah.
And he sent, I think I sent a few of these actually, and he
Okay.
sent a letter back
Oh, he
saying,
probably hates you now.
no, well, no, he like I was learning a lot and I was like, oh, I didn't realize this, but he actually diagnosed them with
Ah,
limbal stem cell deficiency. So then
yeah.
in my head, I'm like, how do you tell the difference between those early stages of dry eye and this condition?
Hmm.
Because
Yeah.
I like every letter that he wrote back, it was limbal stem cell deficiency, and
Named
I
it.
was like, come on, doctor, I'll go like
Yeah.
really? And then I was just like, okay. But
Yeah.
yeah, I was trying to look more into that, but
Yeah.
what are some tips that you can give
Yeah.
on that specific
Yeah.
condition?
So in the most early stages, it's going to be really hard to tell.
Hmm.
But arguably, when you have early stage limbal stem cell deficiency, if you think about what's actually happening on the corneal level, the limbal stem cells are not able to differentiate into epithelial cells. That means the epithelium is not healing, right? So
Hmm.
you get this kind of persistent, epithelial defect, or just kind of this really unhealthy epithelium. But actually, one thing that's pathognomonic for limbal stem cell deficiency is actually peripheral epithelial thinning. And so a
Oh.
lot of the
Oh,
OCTs nowadays can do anterior OCTs.
yeah.
And on top of that, you can actually do an epithelial screening. And so it's a
Okay.
different setting. You have to be able to pull up to be able to see the numbers, but you can actually start to see limbal stem cell deficiency, which can be temporary, by the way, it can be transient. And so very advanced ocular surface disease or chronic contact lens wear, that can still cause this, limbal stem cell deficiency. But when you start looking at that scan, you see in the periphery epithelium, especially, you get this kind of thinning area.
Yeah.
And you won't be able to really see it in early stages live on the eye,
Hmm.
but you can pick it up on
Okay.
an
Wow.
OCT. Yeah,
Okay.
so remembering,
Okay.
of course, the epithelium average thickness is around 55 microns. You're going to start to see your 40s, your 30s, your 25
Oh,
if it's been there
okay.
for a while. And that'll
Okay.
be your first marker to think, okay, there's something happening in the periphery, epithelial, the limbal stem cells are involved. That's going to
Okay.
be kind of your first clue that something is off there beyond just a typical dry eye per se.
Okay.
Hmm.
Okay.
Um, and then sometimes if you're working on getting the tissue to heal and then you stain them and you start to see this kind of swirly, kind of like whorl-like keratopathy pattern,
Hmm.
that actually is a really strong indicator there's something going on there because that's actually how the corneal epithelium tries to migrate to be able to fill in the center. And so when it's doing this and it can't quite do it well and is stuck there, you know that the epithelial cells that have been differentiated aren't moving in the right way. And that should be another indicator that there's something going on at the limbal area. So that
Oh,
staining
Yeah.
okay.
pattern is going to be really key. And you have to wait. You have to stain and you have to wait a little while,
Okay.
let the pooling go away, and then look with the cobalt light to be able to see. And then you'll sometimes be able to pick up this kind of swirling sort of pattern as well
Oh,
too.
Okay.
Yeah.
Okay.
wow.
Another one, sometimes when someone's had it for a long time, sometimes you may find that it's you might see kind of at the very edges this sort of we call it conjunctivalization of the cornea. So it literally looks kind of like this panisy kind of appearance to it.
Yeah.
And what they've actually found is actually when they did OCT angiography on it, not that that's going to be something that you would do every day, because it's not really needed, but that they
Hmm.
found that it actually shows that the sort of the vessels of the conjunctiva encroaching into the cornea. It's actually the cells are turning into conjunctival cells. And
Yeah.
so you can
Oh,
actually
okay.
see that. So when you start to look, especially if someone has chronic SLK, for example,
Hmm.
looking at that eyelid, and you can see this sort of haziness. It's not really true active pannus, or it's not
Okay.
active neovasc, but you see this kind of sheen, this kind of almost whitish appearance where it looks like the conjunctiva is kind of starting to encroach in.
Yeah.
Think of like a pterygium kind of starting to move
Yeah.
inwards.
Yeah.
So those kind of things is also a good indicator that there's been limbal stem cell deficiency for quite some time.
Right.
Okay. What would
Um,
you use to slow that down? Like a steroid again, or
So you
basically?
can certainly. You'd almost think about what you would treat for, let's say, dry eye disease, but like instead of, level one, level two, or stage one, stage two, dose two, you're going to like three or four. You're
Oh, okay.
Hitting
modulators,
it
steroids
hard.
will be part of it. Yeah.
Okay.
Scleral lens maybe is going to be a good
Hmm.
option there.
Okay.
Biologics will be good.
Yeah.
But yeah, you're going to want to treat those quite aggressively,
Okay.
because they're going to be much more susceptible to progression.
Okay.
Hmm.
Okay.
Yeah.
Limbal stem
I
cell
know every
deficiency. I don't
single
think
letter
I've
back.
said that since 2019.
Yeah,
Mm-mm.
there you go.
Nope.
Yeah. Yeah.
Oh my
Um,
God.
are there specific corneal conditions besides corneal perforation that
Mhm.
you believe should require an immediate referral to a corneal specialist so that the patient can be seen within, 24 to 48 hours?
Yeah. Um, yeah, that's a good question. The challenge is it really depends on, maybe I'll say it this way, it really depends on your comfort level, first of all, because I never want anyone to have to go and try to manage something where they don't really feel comfortable doing it. They're just going to try because, because they think that that's the right thing to do, or they think that, for
Yeah.
optometry, so if you're
Yeah.
not comfortable, please send it because we don't want you to have to try to do something you're not comfortable with. And over time you learn and you become more familiar. So as a baseline, competency and comfort is going to be kind of your deciding factor for what to refer. But for kind of the 24-hour stuff, I would probably say like your MKs are going to be the ones where you're going to want to send them pretty
Mm,
quickly. And arguably you can empirically treat some, but if you're not really quite sure exactly what kind of infection it is, getting them in soon for a culture is going to be really important.
hmm.
And so, you may potentially start them on an antibiotic, but if you can get them in for a culturing, that's going to be really, really important. This is kind of a rare one, but sort of your ocular cicatrizing pemphigoid patients, which is
Oh,
going to
wow.
honestly be really hard to tell, but those are going to be the ones where they're having a flare up. And they might have had something before and you're kind of just monitoring them. But these existing patients with sort of a little bit of, well, a lot of scarring, if you pull their fornix down and it's shortening and is actively inflamed, those have to go. Those have to
Mhm.
go to cornea specialists because those need arguably even IV steroids or something really
Wow.
intensive because that can go down really, really quickly. And
Got it.
Oh.
those are going to be the ones where, and it depends, right? If you get someone walking into the door and they've got, a perforation, those are going to be easy to be like, okay, you got to go. But it's those ones that you're kind of monitoring, and many people are going to be in co-management situations where they're either in a rural practice or their clinic is well established with a cornea specialist. Those are the ones where some of those patients who have, let's say, significant scarring, you've been working with them for a while, but something just looks different on there, and it
Hmm.
seems like there's a progression in vision, there's more pain, and then the appearance just looks very different. This is where I'm a big advocate for anterior segment photos. Having those you can
Mm.
compare back and say, okay, this actually looks very different. Those are oftentimes the ones where you're going to want to either send a photo to whoever's triaging, or give them a call and say, hey, this is happening. And for certain cases like those, especially when there's co-management, those are the ones that we'll make room for. But those are kind of off the top of my head, kind of the ones that are kind
Yeah.
of that same day emergency.
Mhm.
Yeah, the ones that I can think of right now anyway.
Well,
I
that's good
would
to know.
I would actually think of one more because this
Yeah.
happened to me once,
Yeah.
unfortunately.
Mhm.
Um, if a patient who's had like a corneal transplant,
Mhm.
all of a sudden is getting like
Yeah.
stromal haze or like a big
Yep.
like
Oh,
sudden vision
yeah.
loss, how do you
Yeah.
handle a transplant patient, I guess?
And
Yeah.
are they supposed to be seeing an
Yeah.
ophthalmologist every
Or
year, I
are they
thought?
like good
With
to
like,
go after
Yeah.
like a couple of years? Do
Yeah.
they get like sent
All good
out?
questions. Like, tell me what to do with these.
Yeah.
So, yeah, I think a corneal center of some kind doesn't have to be like, well, I mean, if you've got optometry working at corneal space, then they can do that as
Hmm.
well. But generally, yes, because the main risks for a corneal transplant patient, especially your full thickness transplants, are going to be rejection, and
Yeah.
as well as glaucoma. And so those are the two things to be monitoring. And oftentimes their medications may need to get changed. They're probably going to be on some kind of a prophylactic steroid and a
yeah.
pressure lowering drug for that reason. So they're
Hmm.
going to be on some things that need to be managed to see where that needs to be changed or not. So if they're very stable, a year is great. A lot of times it's going to be every 6 months, maybe 9 months, depending on if they've got sutures in, all these kinds of things.
Hmm.
Um, but yeah, the rejection progress, I guess, it is usually not going to be sudden. You're hardly going to
Yeah.
ever have someone with a full thickness transplant coming in and that was the first day that
Yeah.
their inflammatory kicked in. So it's probably likely that gentleman probably had that for brewing for a while, and
Oh,
you
he
got
did. He
lucky.
just
Yeah,
decided, let me go find Dr.
yeah,
Bilku in this
yeah,
area and
yeah,
go ask her about my friggin'
yeah,
cornea. And I was like,
yeah.
great, great.
Um,
I can't wait to talk to you about it.
Yeah, and to be honest, if you weren't sure of the history, you're like, I don't know what this looked like before, there's nothing wrong in what you did because
Yeah.
you want to make sure the question is this going to need any kind of surgical intervention, right? And so
Yeah.
you bring up a really good point. If someone has any kind of surgery that really requires some monitoring and they come and they land in your chair, whether you knew them or not, and there's something going on, it's you can refer that, depending on how severe it is, you can refer that same day and most of the time that's going to be warranted.
Okay.
So think about, for example, corneal transplant. One of the ones with the corneal transplant is looking at the suture lines to see whether or not there's any signs of infection. That can be a big
Mm-hmm.
problem because once those suture lines get any infection, it's got basically a clean pathway all the way through, right? Remembering you've got that host tissue and donor junction, that's basically an open line all the way down into the anterior chamber, and that can be problematic very quickly. Yeah, I think signs of rejection is one. If you see someone, let's say, with like a DSEC, like an endothelial transplant or something like that, and you see that it's actually separated, that probably needs to get sent so that they can get a rebubble in there so it can reattach again. Anyone who's had
God, separated.
Right.
That's out of my
yeah,
chair right
yeah, if you see it, yeah, to be fair, yeah, if you're hearing that, you're like, hey, wait a second, hopefully your
Yeah.
team get out of here.
away.
But your glaucoma transplant, your glaucoma patients actually, anyone with a trab or a tube, you want to make sure
Yes.
you're looking underneath, making sure that bleb has not eroded because that can catch you by surprise too. And that's going to hurt them. But you lift it up and you can see that, that tube showing up. And you're like, yeah, that's probably got to go.
Yeah.
Those kinds of things. But yeah, anyone who's had a transplant or a surgery that you're kind of like, hey, those are the patients that are going to take a little bit of extra care to see what's going on. And yeah, if there's something going on with those surgeries, those are good ones to send over.
Maybe we could talk about this for like 2 minutes because I know you just talked about glaucoma. We're not going to go over glaucoma or anything, but
Yeah.
you are a big advocate for gonioscopy. Can
Yes.
you give us just a few tips on how to fix these certain problems? Like,
Yeah.
first of all, you mentioned to do gonio on all your glaucoma patients, otherwise you're not really properly managing them.
Yeah.
You say this in one of your Instagram posts,
Yeah.
which we'll plug later.
Thanks
But
for sharing.
but what do you do because when I try to do gonio, I have a lot of patients that can't keep their eye open, or there's air bubbles, and then there's fog, and then, I don't know
Yeah.
if I'm pressing too hard or what's
Right.
going
Right.
on.
Yep.
I know like you got to practice, 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 but
Yeah.
can you give us tips on how to maybe help with
Finesse that a
those?
little bit.
Yeah.
Yeah.
Mm-hmm.
So, if you have someone who really is just kind of like a firm blinker and they're not working with you, those are sometimes the time to either reach for, if you have a gonio with a flange, those are really helpful because you just get that flange right underneath it, and no matter how hard they blink, that's not moving around on you, or a three mirror.
Mhm.
But three mirrors are really clunky, and I
Yeah.
personally really like it. But if you got like a four mirror with a flange, then that's going to be really helpful. But you do have to put a coupling solution, so it takes a bit more time. But if you've got the lens on and you're kind of like, I'm getting bubbles everywhere, one thing that
Mhm.
you can do is you can try to move your lens towards where the bubble is. Because what you're doing is you're actually going to be flattening out that bubble. And so you're getting that
Mhm.
smooth spherical space. And so if you're finding you're getting a massive bubble, just try to almost imagine that you've got the curvature of the lens face, and you want to try to match it to the cornea. And so you're going to actually just try to smoothen out that bubble. And so that might be slight rotations as opposed to pushing in and out. And so
Mhm.
that's probably kind of like when you do this all the time with your 90D, just these
Right.
micro movements in the rotations, you're going to keep it on
Mm-hmm.
the same axis, but you're just slightly adjusting it.
Yeah.
That's going to be really helpful with the gonio lens as well. And so
Okay.
that's one thing to kind of try in your adjustments there as well.
Okay.
Sometimes having the right light beam, you don't want to make it too wide or too long because you're going to catch a lot of glare doing
Yeah.
that. So shortening it up a little bit and then kind of giving yourself more dark space, if you will allow you a little bit more space to move as well too. And then the one thing when I was doing a gonio workshop, I found that one of the biggest things of positioning was the actual front face of that lens should be perpendicular to you. And so oftentimes we lose all of the light because it's kind of shifted over. You're actually on the
Yeah.
eye, but it's aimed over the other way. So your slit lamp is
Yeah.
not even beam is not even hitting it. So kind of walking through, is the face facing me? Is the posterior face on the curvature of the eye? And then filling out that beam, that'll get you through most things.
Okay.
And then learning how to kind of almost use the edge of your gonio to lift the eyelid so that you're catching it and then you're lifting and putting it right on. That'll be helpful as well
Helpful.
too.
Mm-hmm. Well,
Okay,
thank you
great.
so much, Sophia, for all of your insights on the
Yeah.
cornea. We're so happy that we were able to do two, parts of this episode with you. We learned so much, and I think our listeners are going to get such good value out of listening to this because, yeah, it's really good to get that reminder of just because the cornea looks clear and you skim it for 2 seconds, that doesn't mean that it's actually clear. Like we need to
Right.
pause, we need to take a look at every layer. So
Yeah.
tomorrow is the
There you
first
go.
day I'm going to start looking at those layers.
There you go.
Thank you again, Sophia, for joining the Four Eyes podcast, and we hope you enjoy the rest of your night.
Yeah. Okay. Take care.